Welcome to Genomics Now, a podcast series where you can learn how genomics is developing in England's NHS. This podcast series is recorded in 2024 and is part of the North Thames Genomic Medicine Services Educational Toolkit. In each bite-sized episode, we explore what is changing in genomics. We answer the questions on genomics we've been asked by the different healthcare professionals. We talk about the ways genomics may impact different healthcare roles and how genomics can be used to successfully improve patient care. Hello, I am Dr. Shazia Mahamdallie, and I'm part of the North Thames Genomic Medicine Services Workforce Education and Training team. In today's episode, we focus on the clinician's perspective on NHS England's ctDNA pilot. You can find out more about this pilot, which is currently in progress, in previous episodes in this series. Today, I'm excited to hand over the microphone to Dr. Alistair Greystoke. Alistair, welcome.
Thank you very much. So my name is Alistair Greystoke and I'm a Professor of Oncology up at Newcastle. And I was a national lead for the circulating tumour DNA project that is ongoing as described. I'm delighted today to be joined by Will. Will, do you want to introduce yourself?
Sure. So my name's Will Ricketts. I'm a consultant chest physician, so respiratory doctor, and I work at Barts Health NHS Trust in East London, where I'm the lung cancer lead there, and also for the North East London Cancer Alliance.
So thanks very much, Will. And I'm really interested to hear from your point of view as a chest physician, speaking as an oncologist, how this pilot has looked to you and what impact it has had on your practice. So can you just tell me, to start with, how you got involved in sort of ctDNA testing and involved in the services?
Yeah, sure. So just for the listeners who may not know how a lung cancer pathway tends to work in the NHS. So we as the chest physicians normally lead on the front end of the pathway, so very much the diagnostic side. And then once we've made a lung cancer diagnosis, pass our patients on to our treating colleagues, so oncologists like yourself, obviously, and also thoracic surgeons being the main people we tend to refer patients to once we've made a lung cancer diagnosis. The ctDNA project came about for us as part of the NHS England pilot. So the North Thames GMSA was one of the phase 1 pilot regions or areas, and then Barts Health was one of the phase 1 pilot sites. So we were involved in sort of a lot of the planning and ramp up in autumn, winter 2022, and then started being able to utilize these new tests on our patients early in 2023. So our first cases were in January 2023.
And just to highlight for people who haven't listened to the previous podcasts, in phase 1, it was just 100 samples per region going off to a commercial provider, as opposed to phase 2 and now phase 3, where we've been sending them to the North Thames Genomic Laboratory Hub. So you've been doing it now for coming up to 18 months. Can you sort of describe the sort of patient benefits that you've seen from this approach?
Sure. So we've now tested over 100 patients. So we're running at, on average, that makes it about 6 a month. I think we've probably ramped up, as it were, partly because, as you've just said, there were limitations on the number of cases we could do at the start, but also our pathway, I think, has become slicker. We've become better at identifying the right patients to perform the tests on. So, and the idea behind this testing is that we try and make a lung cancer diagnosis faster than we would using a traditional biopsy approach. And particularly within that, get results around mutational testing, so biomarker mutational testing, much faster than we would with a traditional approach. I think the main reason it's faster, so the test probably still takes on average about 2 weeks to come back, which isn't entirely dissimilar to a tissue biopsy. But the big difference is we can front load that much earlier in the pathway. So now if we see a patient, often on the first time we see them, they'll have had an upfront CT scan that will be highly suggestive of a diagnosis of lung cancer. We'll be doing the routine baseline blood testing anyway, and this is almost literally an add-on to those routine blood tests for the sort of subset of our patients for whom this test is indicated. So those patients then go on to get this test result back in about 2 weeks. But if you compare that running in parallel to what their standard pathway would have been from that point, they probably wait a week for a PET scan. They might then wait another few days to a week to have their tissue biopsy test, so often an endoscopy, scheduled, another week or so to get the basic results from that back, and then another week or two to get all the biomarkers back. So this is probably speeding up these patients' pathways by about 2 weeks or so on average.
Yeah, and that's very much been our experience in the Northeast, where we've been involved in the pilots as well, that because, as you say, you just get the sample away quicker, it takes a couple of weeks. It does seem to make a 2 to 3 week difference in when you potentially have a molecular result available to you. Well, you talked there about making your service slicker and doing the blood sort of early on. Is there any hints you've got for other people setting up the service like that can make their service slicker from the start?
So obviously, as you know, but again, for the listeners who may not, these tests are currently only indicated in patients who have stage 3 or stage 4 lung cancer, so advanced stage lung cancer. When we prep our clinic lists, every clinic, one of either myself or one of my consultant colleagues will go through the list and sort of prep the whole list. And as part of that, we will be looking at the scan results that are already back, flagging for reporting the scan results that aren't, or the scans that have happened, but the results aren't yet reported. And as part of that process, we'll look out for patients who clearly have stage 3 or stage 4 disease. So the patient has already got metastases on that baseline CT scan, then we know that they are a potential candidate for a ctDNA test, and we will flag that on our clinic prep list so that when we see them in clinic, we've got that little nudge or reminder both to ourselves and the specialist nurse who's in the clinic with us that this is a patient who we should be looking to do a ctDNA test on that day as part of sort of routine clinic visit.
Okay, that's a really good tip. And so moving on, you said you've done about 100 patients, so you've had about 100 reports back now. They're not the easiest reports to read to start with. So how have you communicated the results to the other members of the MDT? And then moving forward, how have you found giving the results back to patients, or has that mainly been an oncologist's job in your centre?
So you're absolutely right. The results aren't always the easiest to interpret, and they sometimes come at dozens of pages long. I think our record was over 50 pages that had to be split into 2 PDFs. Yeah. But actually, certainly to a simple chest physician like me, you can get most of what you need from the front couple of pages. So you get a summary result in the first few pages. We then tend to, and particularly in the phase 1 and 2 pilots, tended to discuss every patient in our local genetic MDT. And I think both through preparing the cases to be discussed and then I found it really helpful to be able to attend myself. But even if you can't, then reading the MDT sort of pro forma outcome afterwards, that you pretty rapidly learn to speak enough of the language, as it were, for what I need to know as a chest physician, what I need to convey to my patients. From the point of view of sort of conveying to our MDT and going back to your sort of question about hints and tips, we've actually tweaked our MDT pro forma a little bit to include a box as to whether a ctDNA sample has been sent. If so, what date was it sent, so that we've then got an idea of when we might expect the result and whether we need to start thinking this is taking a bit long and proactively face the result. And also another box for the actual result when it becomes available, so that all goes into our standard MDT pro forma, which then sort of prompts that discussion in our treatment MDT. From the point of view of explaining the results to patients, actually, I think I don't need to know a huge amount about it at that stage, because I don't think, in a way, the patient doesn't need to know a huge amount about it at that stage. So what I tend to say is when we're talking about collecting the blood sample in the first place, I'll talk to them about, I tend to use a phrase like blood biopsy, and I tend to explain that this is to look for cancer cells in your blood. The test isn't always positive, and if it's negative, it's not it doesn't mean you haven't got cancer, but if it's positive, it means that we can speed up your diagnosis and get the diagnosis back a lot quicker and start you on treatment a lot quicker, which then tees it up for when you then have the follow-up consultation with them with the results. And then you could, obviously makes it easier to then explain the blood test. I normally say something like the blood test has come back positive, showing cancer cells. They look like lung cancer cells. And then if that is the case, then I'll hopefully be able to say, and one of the biomarkers is positive, this is good news for you, because it means we've got your diagnosis quicker. It means we can get you on treatment quicker. And it means that your cancer has a targetable mutation, so that we're hopefully going to get you on a bespoke treatment that's going to work for you. And then the way our setup is, they wait between sort of 2 and 6 days usually to see the oncologist from that point onwards. So I say the oncologist will be able to explain a lot more about this and the treatment when they see you in clinic, but it gives them a little bit of time to think about the questions they might like to ask as well.
No, that's really good tips. Just in the last minute or two that we've got together, I'm sure there were some hurdles that you came across in setting up the service. What do you think was the biggest one from your point of view?
I think they really all boil down into sort of variants on a sort of logistical admin type theme. So as I've already said, flagging patients in clinic, but remembering who to flag, remembering who the candidate, tracking who has had samples sent, making sure patients do get added to the genetics MDT, making sure someone can attend the MDT to discuss the cases. So very much administrative. And then we got that quite slick in our first hospital that we rolled this out in, and then sort of reinvented that wheel as we rolled it out to our other local centres. But at least once you've done it once, it becomes a bit easier to do it again. I think the other thing we found was people were a bit too keen and actually sent tests in patients who perhaps weren't appropriate. So didn't definitely have lung cancer or didn't definitely have advanced stage lung cancer. But so I think there's worse things than being too keen.
Yeah, no, I think you're right. And I think you're right about the logistics and, going forward. I've been very impressed by how the chest respiratory physician community and the lung cancer nurse community have taken on the pilot and this extra work that they do need to do, but hopefully for patient benefit. And it does set us up for some of the really exciting advances that may come forward, including using things like cfDNA in screening and in earlier stage disease, and maybe even monitoring response to treatment. That, as an oncologist, I'm very excited about. So thanks very much, Will. And with that, I'm going to pass back to Shazia to wrap up.
Thank you both for sharing those clinical experiences and Will for those fantastic tips that are really practical that people can follow and what you've learned from this pilot. So I really enjoyed this episode. Thank you for listening to this episode of Genomics Now, a series of conversations hosted by healthcare professionals. The North Thames Genomic Medicine Service aims to complement other genomic-focused educational tools with these bite-sized podcasts. So do visit our website for more resources and updates on genomic-based clinical developments and research. If you've enjoyed this episode, don't forget to share your thoughts and spread the word by tagging the North Thames Genomic Medicine Service on social media.